Hi Dennis, how are you? Thank you for coming.
Hi Katarina, doing well. How's your day going?
Good, good, thank you. Hello everyone, we'll start in around 4 minutes. Thank you for coming. Hi Sean, welcome. Thank you so much for coming. We'll wait another 1 or 2 minutes and then we'll start. I'll start introducing you to the audience. So, yeah, thank you and nice meeting you here. Hi Gilbert.
Hello, everybody.
Hi.
Yeah, hey, Dr. Chen. Thank you so much for making it. We really appreciate it. And nice to meet you here. I hope your Friday has been going well.
Yes, thanks, Catherine, and thanks for the invitation. Yeah.
Yeah, it's an honor to have you here. We can start slowly, and I guess people will take a few minutes still coming in, but I can start introducing you, and um, and then Dennis here. We started. I hope that's okay with you. We wanted to start. We started doing this week. That we ask the scientists a little bit, a few questions, so that the audience will get to know you a little bit. Also to promote you as a person, as a scientist. I hope that's fine with you. And then the stage is yours to give a summary of the of your work. You don't have to stay within this publication. I know you have a lot of very relevant studies that you've done related to COVID. So if you would like, we can, give a broad overview of your work. But yeah, thank you everyone for joining our Science Society room today. Um, Let me introduce you, Dr. Chen. It's a great honor to have him here. Let me give you a little bit background information, Dr. Chen, he's at Cambridge University in the United Kingdom. He's a postdoctoral research associate there, and he did his education at the Chinese University of Hong Kong, and his main work is about building, analyzing data and visualizing data from hospital-based records to support clinicians and patients-led research. And he evaluates the effect of interventions on patients, and he explores the potential risk and protective factors of health service utilization and status. So I think it's a very important field, especially with the recent pandemic, but also for other broad health issues, related issues. And his top areas of expertise are COVID-19, dementia, and schizophrenia, and other. And he co-authors 37 peer-reviewed articles in the past years. So yeah, it's a great to have you here, Dr. Chen. Thank you. And Dennis, go ahead.
Thank you, Katerina. Thank you, Dr. Chen, for honoring us with your time and presence. We'd like to ask, what was the pathway for you to become a scientist? What led you to science?
Sorry, can you repeat the question again? I think I missed something.
Sure, sure. How did you end up being a scientist? What was your pathway?
Sorry, what the means pathway? Yeah.
So when you began, what were your first experiences on your path to becoming a scientist that you are right now?
Yes, I think I don't know how to answer this. I think I just come to the Cambridge for the research after I graduate.
Okay, that is also a valid answer. Thank you. Katerina, back to you.
Yeah, Dr. Chen, if you would like to give us an overview.
Yes, thanks. So the next I will begin, or next or I will do what? I'm not sure.
We can begin with your presentation.
Okay, thank you. Yes, and thanks for the invitation and thanks for the time. Yes, today I will give a brief talk on the publication on the paper we published, and the topic is the association between lithium use and the incidence of dementia and its subtypes. And the first is the background. Dementia is the leading cause of death and disability in elderly, and there was about 50 million people had dementia worldwide in 2015. And this number is projected to be tripled in the next 30 years. So preventive interventions that could delay the onset of dementia even modestly would provide a major public health impact. It has been estimated that delaying the onset of dementia by 5 years would reduce the prevalence and the economic impact of dementia by 40%. Lithium has been proposed as a potential therapy. It has positive effects in cell and animal models of dementia, and there is evidence for its neuroprotective effects from experimental research and from clinical studies using brain imaging. Two meta-analyses and one RCT study has also suggested that lithium has beneficial effects on cognitive performance in people with mild cognitive impairment and people with Alzheimer's diseases. However, it is unclear whether lithium can delay the onset of dementia. So in this study, our primary aim was to assess the association of lithium use with the incidence of dementia and its subtypes. The subtypes we focused include the Alzheimer's disease and the vascular dementia. And our second aim was to examine the degree of association by the duration of lithium treatment. Before we started work, we hypothesized that lithium would be associated with a reduced risk of dementia attacks. And this association would be seen in both short-term and long-term lithium exposure. To explore the question, we performed a retrospective cohort study using data from electronic clinical records of Cambridge. The database is called CPFT. CPFT provides mental health service to a population of about 0.9 million people and covering both urban and rural areas. All study examined those referred to the CPFT at some points to secondary care for mental health services. The mental health records contains patients' information recorded by the physicians during their routine treatment, including like structured data, age, sex, marital status, ethnicity, coded diagnosis, and some unstructured data like free text notes. For this study, we examined the data between the 1st January 2005 and 31 December 2019. For the cohort of patients exposed to the lithium, each patient's origin time was defined as their earliest recorded exposure to lithium. And for the exposed cohorts, non-lithium user, their origin time was the latest CPFD registration data, or the 1st January 2005. The follow-up was until to the patient's final records, death, or the first records of dementia, whichever occurred first. In this study, we only included patients whose age was 15 or over at the baseline and had at least 1 year of follow-up. In this study, we excluded patients who has a pre-existing diagnosis of mild cognitive impairment or dementia. We also excluded the patients. Their follow-up time was very small, like small than 1 year. The outcome, next is the outcome. The outcome we focused is the dementia. The dementia was diagnosed and classified based on the ICD-10 code. And for example, the code F00 is for Alzheimer's disease. The code F01 is for vascular dementia. F02 and F03 is for dementia in other diseases or unspecific dementia. G30 is also for Alzheimer's disease. And so from the database, we can extract the outcome. For the exposure to lithium, the exposure to lithium was judged based on patients, whether patient was prescribed lithium or had a serum lithium level of 0.3, 0.2 or higher. The duration of lithium exposure was calculated as the range between the earliest and the latest date of lithium events. And for the data analysis, we also included some confounders or called covariance. We investigated several social demographic variables like age at baseline, sexual, marital status, and ethnicity. We investigated smoking status. We also investigated the co-prescription and comorbidities as potential confounders and treated them as binary time-independent variables. And the medication and the medication of the comorbidities variables was we considered include whether the people take the antipsychotics, whether the people have dementia, whether the people have alcohol-related disorders, whether people have mania or bipolar disorders, whether they take, whether they have diabetes, and whether they have hypertension, whether they have central vascular disease, and all this was confounders we need to control. And for the model we used the Cox proportional hardening model to examine the association between lithium exposure and the risk of dementia. And to further control for the possible selection bias between lithium exposure and non-exposure, the Cox model were adjusted by the inverse probability weights. The inverse probability weights were deprived from the probability scores generated by a binary logistic regression. And we also conduct a series of sensitive analyses to check the robust of our results. The sensitive analysis we conduct include use a longer criterion to identify common maintained medicines, use a longer follow-up time to exclude patients registered in the CPFD temporarily. We also do a sensitive analysis by excluded patients with recurrent depression. And for the results, and finally we followed 548 patients exposed to lithium, and about 30,000 patients unexposed to lithium. When we compare the basic information between the two cohorts, we found that there was some difference in the baseline of patients between the lithium user and the lithium non-user. Patients in the lithium user group were more likely to be married, more likely to be current or former smoker, more likely to have used antipsychotic, more likely to have comorbid depression, more likely to have bipolar disorders, more likely to have hypertension, more likely to have central vascular disease, and more likely to have diabetes. After we adjust the data by the inverse probability weights, the baseline characteristics between the cohorts were well balanced, except for the comorbid bipolar disorders. After we control the confoundings, include the social demographic, smoking status, and other medicines or other comorbidities, we found, compared with the patients who never take lithium, exposure to lithium was associated with a lower risk of dementia. And this result was consistent in the subtype, include Alzheimer's disease and vascular dementia. We also analyzed the data by duration of lithium, means categorize the lithium into 1 year, 1 to 2 year, 2 to 3, 3 to 4 year, like this. And the analysis and the results we found suggested that So the lithium was the lithium protects effects in dementia was significant at short term. Uh, for lithium users less than 1 year, and long term for lithium use more than 5 years. But the effects at the intermediate duration were not significant. But this result may because of or simple size is not very big, especially for the lithium user. And as for our sensitive analysis, all the sensitive analysis confirmed our results that lithium was associated with a lower risk of dementia and its subtypes. Our findings supported the hypothesis that lithium is associated with a reduced risk of dementia and its subtype. These associations are generally consistent with previous studies of clinical data from countries like Brazil, like the US, like Denmark. But the results is not consistent with another UK study and one study conducted in Taiwan. The difference may be because of the simple selection, the study design, and the confounders we controlled. Even though the significant results, but all analyses have some limitations. The first one is the handling of bipolar disorders. Bipolar disorders is a significant risk factor for dementia. In practice, in clinic, lithium is primarily used for bipolar disorder, but also as augmentation therapy for recurrent depression. And to test the robust of our results, we needed to conduct two sensitive analyses to check the robust of our results. And sensitive analysis confirmed our results. And another limitation is that all sample size of patients using lithium was small, and this limitation was specifically reflected by the wide confidence interval of our results. And thirdly, the mental disorders and the physical comorbidities we have controlled may suffer from undercoded, and this possibility always exists with the use of clinical data, and can bring some unmentioned bias. In our study, the main answer to the question is what is the dose-response association between lithium and the incidence of dementia, and these questions in the more focus in future study. And I think caution should be taken when people try to drawing conclusion from our study to the general population, because our cohorts differs from the general population, as our database was of patients treated for dementia conditions, for mental health conditions. We cannot exclude the possibility that the lithium effects will be a different one in the general populations. And so in future, more studies involve the general populations are also needed. Yes, this is a very brief introduce, and yes, that's all. Thank you.
Yeah, thank you so much for this great introduction. This is such an important study and work that you do, so thank you for that. And I want to ask first if Dr. Shar, Serena, or anyone here on the stage has a question. Please go ahead. I know that Tony Kendall had also a few questions who is in the audience. Please raise your hand if you want to ask them personally or if I should ask them. So yeah, please go ahead, everyone.
Dr. Shah, the floor is yours.
Thank you so much, Katerina and Sean, for very good paper. I was not able to going through the whole paper because that was just the abstract part, but I was just wondering, your data just makes sense to me because even for some of the patients with the Parkinson disease, I remember back in time we had some patients that experienced the same situation and they were under medication with the lithium and we had a hard time, and for the period of the time we were able to control the situation, but somehow the dose changes was required. So even from that perspective, your data and the result makes sense to me. Thank you for sharing.
Yes, good questions. Yes, at the beginning of a study, we try to include as much as possible subtype of dementias besides the Alzheimer's disease, vascular dementia. Also include there are also some type of dementias like dementia with Lewy bodies and dementia with Parkinson's disease. But finally, we don't analyze this because the sample size is too small. So for other type of dementia, I think we still need more data from multi-set beyond Cambridge.
Did that answer the question? And yeah, I'll Dr. Tony Kendall, he asked me to ask his questions because he is having background noise where he is. So he asked if you also look for if you take into account adjustments for bipolar affective disorder, also in the general population, or if you looked for other cofactors in the general population or in any of your groups studies.
Yes. Yes, good question. Yes, in our analysis, yes, the bipolar disorders we need is a big confounder for analysis because in clinic, lithium was primarily used for bipolar disorders. So we did two quantitative sensitive analysis to check the robust of our results. First one is treat all the lithium user as bipolar disorders, and the second one is exclude the patients with recurrent depression, another indicator of lithium user, to check and both confirm our results. And for the results to the general populations, and we don't have the confidence because the patients we focused on has cancer of mental disorders, and all of these are the risk factors for dementia. So the lithium may be effects for people with bipolar, for people with recurrent depression, but we are not sure whether the lithium was in fact was for general population. And so more analysis is needed in future.
And he is also asking what the duration and the dosage of lithium treatment was included in the study, and if there would be enough data or how much data you would need to make a dose-dependent curve, basically.
Yes, for the duration, yes, for the duration in all data in all analysis, we categorize the duration of lithium into less than 1 year, 1 to 2 year, and 2 to 3 year like this, because there is no standards how to group the lithium duration, so we just use 1 year as the standard. We also make a sensitive analysis. Use 2 year as the standard to group the lithium duration, and it also confirm our results. For the sample size of those response, and I think it need I think it need a calculation based on the formula to calculate the sample size. But for all analysis, I think, but for all data, the sample size is enough. But the bigger challenge for data is that there are a lot of missing value of the lithium dosage. So we failed to further explore the dose relationship. I think maybe I think this problem may be common for other sets. So if future researchers want to explore this relationship, explore the dose response relationship, besides the choice of RCT study, I think maybe redo the analysis by involving of multi sets is possible.
A question: is there any insight into whether the mechanism is lithium acting directly on the neurotoxicity of the plaques, or is it an indirect effect? Is there any mechanistic insights?
As far as I know, when I read the paper, first I just know the epidemiology. I'm not the biomedicine. I'm not a professional in biomedicine, so actually I don't know the behind the mechanism. And maybe these questions need answered from people in other subjects. Sorry.
Yeah, thank you so much for these answers. Eric, did you have a question, Victoria?
No, not at the moment.
Yeah, I think it's really interesting how across such a, I mean, the study is pretty big compared to other studies, how you could have such a stable result. That's not very common, is it, to have across the population such a stable result? And this reminds me of a study that I read about, that in Texas apparently there are a few places where the lithium in water that naturally occurs there, so it's in the drinking water, is relatively high. And there was a study done that there are less mental health issues, including suicide rates, are significantly lower in places where lithium concentration in the water is relatively high. Is that something that that you would consider studying as a follow-up to, like how nutrition wise, or the natural lithium intake um, changes has an effect on maybe dementia in the future, or is it not, or is maybe the finding so low or so variable that it's not realistic to get the result?
Um, I think the next plans not depend on me. It depend on my leader. So currently I hope our team can have the chance to do a RCT study to check the to check the to check the to check the clinical evidence, but I'm not sure.
Yeah, interesting. I know we didn't really discuss this beforehand, but I know you have also papers that looked at long-term mortality following COVID infections. Would you be also fine to maybe share a little bit of the COVID-related studies and also the mental health outcome after COVID vaccination study? Would that be fine with you? I could share the link here with people. If you could give us a short summary, maybe.
Yes. If people interested in that results, yes, I can share. Yes, for the dementia and the COVID, yes, we should have a plan, have an ongoing plan. Yes, we are trying. At the moment, we are studying. We are explore the long-term effects of COVID on people with dementia, and the, the data was still under analysis.
Yeah, I posted the link here of this paper where long-term mortality following COVID infection in people with severe mental illness. Um, I don't know if you can give us a short summary of this paper.
Okay, for a moment, let me have a.
Oh, I thought you. It's fine if you don't, but I just want to mention it that you.
Yes, maybe next time. I think I don't make a preparation for that paper.
Yeah, it's fine. I'm sorry about that. Yeah. So yeah, I think you do a really interesting job at looking at clinical data in general and looking for what what actually helps. So, which are the other projects you're currently working on? So you have the COVID projects and the lithium dementia projects. In your profile, it's also mentioning that you're working on schizophrenia. Is it similar? Is it also lithium related?
Sorry, I think I don't get the questions because the internet was interrupted just now. Can you repeat the question again? Sorry.
Yeah, I just updated the link back to your paper. So in your profile, it's mentioned that you also. Can you hear me better now? Just
Yes, it's better now. Yes.
okay. I'm sorry. Um, so that you also study schizophrenia. Is that study also lithium related? Um, do you also look at what the effect of lithium has on schizophrenia long term?
The work on my hands is dementia related. At the moment, we are planning to do some work also related to lithium, but it's still in prime step. So, well, I'm not sure.
Yeah, thank you. Does anyone has more questions related to this study? So the patients, the 29,000 patients in the cohort that has been treated. So where is it all from the clinics you work, or is it all UK based? Like, what's the where do the patients come from, or is it also from other countries' patients?
Is the data is from the clinical records. How to say that? And uh, um, when patients visit the doctors, their information will be stored in the computer in the internet, and the patient will be asked whether they want to share the information of their data to researchers, and in the UK, and the digital data related to the clinical records is very well developed data. So we can apply for the access to this database after we get the ethical approval.
And do you think, based on your study, it would be helpful to prescribe lithium at a certain age in people that have in the family dementia a lot in the family as a preventive care?
I think our study is just the primary analysis. In the way of clinical, there are still a long way to do, especially the evidence from RCT study is necessary. So I think we just or study or just give some clue for future researchers cannot be used as a final evidence, I think.
And did you see, so you didn't see differences of the effect between male and female, or did you? Because we know that at least Alzheimer's has a higher rate in females versus male. Was the effect the same?
Sorry, I think I just know maybe I misunderstand the questions. And for the female and for the male and the female, we included this factor as a confounder, but we do not check the cyber effects by gender. Maybe it's a good idea, but these questions need a bigger sample size, and I'm not sure whether our team have enough sample size to explore these questions.
Yeah, thank you so much. Yeah, that's interesting. It would be really great to see the future of the study. So, are you going to continue to analyze the data in these ways, or are you moving on to another study?
Yes, I think in future, in next step, I will still focus on the dementia. At this moment, I put a special focus on the dementia with risk bodies, and so I hope I can make more contributions to this group of patients.
Yeah, it would be really interesting to to continue to follow these patients and look at post-mortem data? Is that something that is usually, or other patients that are included in the study, will they be available to look at the brain post-mortem if there's a difference between the group that took lithium compared to others?
Sorry, I think I missed the question again. Can you repeat it again?
Yeah, sure. So is it like, are you planning, or other patients that are part of the study, are there going to be post-mortem analysis of the brains of these patients? Because it would be really interesting to see if the damage reflects the data that you show. If they have really less Alzheimer or dementia related cell death in the brain, uh, in the patients that take lithium versus in the patients that don't take lithium, or is the lithium act enhancing just maybe the rest of the brain that's still left over? Basically, the two hypotheses would be possible, that it prevents cell death, or that it just enhances the brain regions that are still functioning.
Yeah, thanks. I think you read some interesting topics. I think I need some time to think and how to come through these ideas. Because before and I don't know, I don't have a think on that. I'm not sure. Yes.
Yeah, it's fine. You know why? I can explain maybe a little bit more why I think both hypotheses are possible. There were studies years ago on monks and nuns that had dementia, and compared to general population, although they had dementia, they were still able to perform their everyday tasks, versus people that lived in um, homes or had like a lot of support. They were not able to perform, to take care of themselves at all. And then they looked later at the the brains, and actually in both groups they saw extensive cell death or loss, so a lot of lesions. But in the monk and nun group, they could still take care of themselves and perform a simple everyday task. And the reasoning was that, the brain that was still there, like the brain regions that were still there, they had to just take, because they never stopped performing these everyday tasks compared to the general population that usually gets taken care of. So that's why I think it would be interesting to see how lithium is acting there.
Yeah. Yes. Yes. You just give me a good spark. I think maybe the data, as far as I know, in UK there is a database called the UK Biobank. Maybe this database cover both general population and clinical patients, and they also have the data of brain imaging. Maybe this database support the approach of your ideas, but the database, but the database is expensive, as far as I know.
Oh, that's great. I would love to see what, I hope, I don't know, I'm very curious right now to see what you come up with. It's just very interesting if lithium, because that will give us clues if lithium can actually prevent the Alzheimer, or slow down the Alzheimer's disease itself, or if it just enhances the the existing the neurons that still survive. So I'm very curious about that data. You have a really interesting job.
Katerina, it's interesting you raised the point of this monk study versus general population. Given that monks and nuns have probably generally a daily practice, it does raise the issue of whether the daily reinforcement of pathways through practices, physical practices, mental practices, may also be a factor in the equation. Obviously, understanding that biology can be a much larger factor in the equation.
Yes, I agree. Yes.
So I had a question, Dr. Chen. You had mentioned earlier in the talk that there's a projection of a 3x increase in dementia over the next 30 years. Is that exclusively COVID related, or is there any indication as to why that projection is that number and not a different number?
Sorry. What projection? Um,
Sure, I'll repeat the
you
question.
mean the number of dementia? You mean
Yeah,
the number of dementia?
yes, yeah. You had said dementia is predicted to increase by 3x in the next 30 years. Why is that?
I think I just get the information from a published paper, uh, 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 just from a reference, but at the moment I can't remember the details. I think I don't know how to and I can't answer the detailed information. Yes, I think maybe it's better to back to the reference for the details.
I'm not sure is a great scientific answer, certainly. And a different question. So, is there any information you can share with us about the percentage of COVID patients that are having dementia-like symptoms?
I think at the moment I don't know how to say that because because I don't at the moment though I explore the dementia though I explore the data among dementia patients with COVID, but I'm not sure. But I don't have the data. All the all the people with dementia, all the people with the COVID. So I can't answer the the person age the question you raised.
Okay. And then the last question on this point, are you aware of clinical trials involving lithium and COVID patients?
Sorry, can you repeat again?
Are you aware of any clinical trials that are looking at the question of the impact of lithium on COVID dementia or any sort of COVID related conditions?
We hope, we hope, but at the moment, uh, I think uh, I'm not sure because it's not just I said before. It's not dependent on me. It's dependent on my leader and whether we can get the funding support for the future for the analysis. Mm, because because RC study like this will be very expensive. So it's dependent on whether we can get the funding support.
That is always a major factor. I do. You'll find that I'm rather adamant that the funding for science should be increased overall. Were there other questions from anyone else? Sean,
Wow,
I see
those
you
were some
flashing. Go ahead.
hard-hitting questions. very conference-like. So perhaps for the future for our speakers, we should give them a list of questions that we may or may not want to ask, so they can be a little bit more able to provide references. I too had those kinds of questions. If Dr. Chen would be willing to perhaps come back in the future and give us an update about some of this stuff. I think it's an exciting field and an exciting problem, because it is a problem that, you know, the essence of you eventually fades away, but it happens so gradually that it's a loss that perhaps not sufficiently many of us appreciate. If there is an increase for whatever reason, it's quite important to address that and find out as soon as we can. So I very much appreciate Dr. Chen coming here today, and I would like to thank you for joining us and giving us your presentation.
Yes, thanks. Yes, if I have the chance, I think I'm happy to share all results. Yes.
Great point. Thank you so much. Any other questions from Katerina? Go ahead.
No, I just wanted to also thank you. And I know from the audience we have a few questions regarding um, what the lithium, basically how it works in the brain, that it helps against dementia. That is not known yet. And hopefully in the future, with analyzing more data sets, maybe from post-mortem brain analysis, we will know more. But I think what Dr. Sean is doing by analyzing more systematically hospital records and to support what actually, like, to support a data-based approach to planning what interventions actually help, which ones are risky, and which have protective factors, is it's something really important, and we definitely need more studies like these. Yeah, and Dr. Shan also did studies with COVID and mental health related disorders. So I would love to have you back to present maybe one of your COVID related papers here. There, I hope we can invite you back.
Yes, thanks for the invitation. Yes, if we can find another time, yes, and if the time is allowed, yes, I can share. Yeah.
Yeah, so we have been talking for around 1 hour. If anyone, I don't want to take too much of Dr. Sean's precious time. So if anyone has any last question, please go ahead. Yeah, just flash your mics. If not, we will. No? Okay. If not, we will. Thank you so much, Dr. Chen. I will email with you maybe to invite you back and talk more about your other studies. I think they are very important for public health. Thank you for your work, and thank you for sharing your time with us. This was really great.
Thank you. Yes, thank you.
Yeah, and everyone, if you like discussions like these and interact with the actual scientists that did the research, please follow the Science Society and come back. We will have more guest invited speakers coming next week. Tomorrow I planned on having like a general science news update. One that I think was really important. A few were really important, also related to the current conflict, and one was that AI experiment generated over 14,000 hypothetical bioweapons and more. So it will be more roundtable discussion, updating on what came out recently in the science and tech world. So we can then decide maybe which guest speakers to invite based on the news and what rooms to plan for, and discuss about new research topics. And on Sunday, we have a weekly Science Society recap planned from now on. So if you missed, for any reason, the guest speakers talk from that week, we will give a short recap and give you another opportunity to listen to it in a summarized way, and ask questions about it. And and next week we'll have more guest speakers on how to a new method to train creativity, why evolution favors symmetry, a mathematician is coming, and also biologists. So yeah, come back. Thank you so much for joining us today for the discussion, and a special thanks to Dr. Chen for his great presentation and for his wonderful work. Thank you, everyone.
Thank you, everybody. Take care and have a wonderful weekend.
Okay, I'll close the room in 3, 2, 1. Bye, everyone.
Thanks, everyone.